Hint Summit is back for 2025, and this year, Direct Primary Care is taking stage at Rosetta Fest. With an exclusive DPC track designed for clinicians, benefits advisors, employers, and healthcare innovators, Hint Summit at Rosetta Fest will feature DPC-focused sessions, top industry speakers, cross-industry networking, and a vendor and partner showcase in the Hint Summit Lounge. Whether you're a well-established DPC or just beginning to explore the model, Hint Summit at Rosetta Fest will offer curated content to support your growth and connect you with key stakeholders in employer-sponsored care. Learn more at summit.hint.com and get $50 off Hint Summit at Rosetta Fest 2025 registration through May 31st with code HINT50. That's HINT50. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
DPC to me is being able to connect directly with patients and having a relationship with my patients and them having a doctor they know they can count on. I'm Dr. Burden-Greer, and this is my DPC story.
Before we dive in, I wanted to share that this episode was recorded on location, about an hour and a half outside Oklahoma City, at the home and clinic of Dr. Katie Burden-Greer, today's guest. She graciously welcomed me out to her 140-acre property, gave me a tour, introduced me to her dogs, horses, and cows, and even fed her bison a little extra so I could grab some video to share with my sons. It was an incredible experience and truly gave me a glimpse into the heart behind her work. Now a little bit more about Dr. Burden-Greer. Dr. Katie Burden-Greer, founder of Outlaw Medical, grew up in rural Oklahoma, where she witnessed firsthand the gaps in the healthcare system, specifically the Indian Health Services healthcare system, or IHS, and rather than accept the status quo, she went a little outlaw and launched her own direct primary care practice. Dr. Burden-Greer is double board certified in family medicine and obesity medicine, a graduate of East Central University and the University of Oklahoma, Boomer Sooner, and completed her residency at the prestigious Mayo Clinic. She's led through crises as chief of inpatient medicine at Chickasaw Nation during the height of COVID-19 and continues to fight for better care in every setting she touches. Outside the clinic, she's Dr. Aunt KK to a big crew of nieces and nephews. She and her husband also have an adventurous spirit, and they enjoy being outdoors, gardening, floristry, traveling, scuba diving, and taking care of their cattle and bison ranch.
Oh, it's nice in the shade.
Yeah, that's awesome. So today's interview is very different. It's very unique. I'm super excited. Dr. Burden-Greer had met me and I met her in Dallas last year. And it totally stuck in my mind this whole time that she said, yeah, I'm opening Outlaw Medical as my practice. And I'm in Oklahoma on the Muskogee Reservation, or the Creek Nation Reservation. And I just think that in such a time that we are in healthcare where there's so much unhappiness with the system. Historically, there's been so much happiness in the Indian Health Services system. So before we go there, though, I just wanted to say that really just to put a geographic location and just paint a picture in the listener's head. But tell us about your even choosing to go into medicine, because you grew up in Oklahoma and you are still an Oklahoman, came back after you went to Florida for school. But when along your journey in life did you say, I want to be a physician doing family medicine?
Yeah, it's kind of a unique story because my mom was an LPN and she worked at the ER in Muskogee, which is the capital of the Muskogee Creek Nation. And she worked there and she'd come home telling me stories and I just ate it up, and I always had an aptitude for science. So I kind of decided at a pretty young age that I wanted to be a doctor. Plus, I was kind of sick as a kid. Like, I would get asthma attacks, get pneumonia, and I would be in the Creek Nation health system as a patient.
Yeah.
And I'd be like, okay, I want to do this. I want to take care of people,
Wow. Yeah. And so the assumption there, because I didn't actually ask you this before we started talking, your heritage is you are Muskogee Creek Nation heritage. I don't even know how you would say that. How
Yes.
is your bloodline of the Muskogee Creek Nation?
Yes.
Yeah.
Yes. I am mostly Muskogee Creek. I am also part Cherokee, part Yuchi. And then I like to tell people I'm a quarter white, but I can't prove it.
That's awesome. My mom says I'm a like this, I don't know, 1/100th or whatever, like fraction Cherokee, but I can't prove that.
Yeah.
So love it.
That's the go-to. It's
love it.
like I am, but I can't prove it.
So when you, as you mentioned your own health history, how easy was it for you to get to be seen? Because you had a little leg up in compared to other people. You had somebody in healthcare in your family. But what was it like if you were like, my asthma is not controlled, I do need to be seen? What was your access like growing up?
That's the thing. It was, even with quote unquote free healthcare for the tribe, the access was so limited. I mean, I can remember going to the ER a lot as a kid because it's not like you can just make an appointment with your doctor or text your doctor or call your doctor. So it was very limited. I mean, there's just way more patients than there are doctors in the system.
And when you, as you were growing up, how far geographically did you live to either a doctor or one of the acute care centers? Because it's my understanding that before a few years ago, there were 2 acute care access hospitals that wouldn't necessarily take care of unstable patients, but for someone who's having a stable but needing to be controlled asthma attack, I would assume that would be an appropriate place to go to.
Right. There was a small community hospital in Okemah, Oklahoma, which you probably drove past on your way here. And that is where we would go for ER visits, doctor visits. It's about 25 minutes away, 20-ish.
From where you grew up?
Yes.
Yeah.
I actually grew up here.
Oh,
not on this exact land, but yes, in Walika.
Wow. Okay. So that's, and I like, what's the worst it got when it comes to like snow and conditions? Because it is it's paved up until here, even to the door of your property. But I just think about living in Omaha that sometimes a 25-minute drive was not a 25-minute drive if there was a lot of bad weather.
Oh, right. Like when there's bad weather, I mean, you just stay home.
Yeah.
Our system is just not built for snow and ice. And usually I feel like maybe twice a year we get a bad snowstorm or ice storm and everybody just stays home.
Yeah. So I'm just like thinking in my head that is probably one of the things that people have most likely found so amazing about your care now as a DPC doctor. So I think about your going off to Florida for training and then you making your way back to Oklahoma. Did you ever think about not coming back home, or did you always intentionally train so that you could come back home and take care of the people you grew up in and around this community in?
When you're a teenager, you think about running away and never coming home. But once my head was in reality, the plan was always to come back and work for my own tribe. My goal was to work for Creek Nation, actually, my whole life. Yeah. And so I went to East Central, a small college in Ada, Oklahoma, and then OU for medical school, and then Jacksonville, Florida at Mayo Clinic for residency. And living in the bigger cities made me realize how much I am not a city person. I really needed my space again. I needed land, and I knew it was going to be rural Oklahoma because I wanted to work specifically for my tribe, but I was open to working for other tribes. Yeah. So it was always going to be back in Oklahoma as soon as I decided I wasn't a city person.
Sure. When you had that self-discovery and you then came back here, I want to ask about your preparation for coming back here in how you either crafted your rotations or how you intentionally went about learning in residency. I just spoke with medical students who were like very much interested in the DPC model, but were wondering about, but if the system only teaches you one way of doing things, fee-for-service way, how do you train enough to be able to be a DPC doctor, to be confident to be serving patients without being in that system? So how did you address your future coming back here? And like you mentioned, even thinking initially that you wanted to work for the Creek Nation itself, how did you craft your experience in especially residency?
I would say for me, I was in such a good program that really taught a wide scope of family medicine, more so than average, because Mayo Clinic, they want their specialists to only see the really weird, hard to treat stuff. So in family medicine, we were seeing everything. Yeah. We were taking care of all the stuff that maybe other places would refer out to a specialist. Mm-hmm. But for us, it was like, oh yeah, type 1 diabetic on a pump. No, they're not going to endocrinology. Yeah. Like, we're taking care of that.
Yeah. It's wonderful that you had that experience. Here, I want to ask about your thought then about wanting initially to work for the Creek Nation or anywhere in terms of, I'm assuming Indian Health Services when you say that. When you were in your third year residency, getting all this amazing training and not necessarily worrying about, could I be a doctor in any system, what were the thoughts about, what was the decision tree like when you were thinking Indian Health Services versus anything else? Were you even thinking of anything else?
There really wasn't even a versus for me. Like, I knew I wanted to do Indian Health Service. I wanted to do tribal healthcare. And I had toyed with the idea of opening my own clinic within the Creek Nation boundaries and maybe partnering with the tribe to try to fund it. But the legalities and the red tape and the funding and the Medicare reimbursements and all the things that were just so against that plan, I just knew I wanted to work for IHS.
Yeah. And it's interesting because for the listeners, something that I learned literally driving here to your property and the town where your clinic is in, I did not realize that, one, if a tribe and nation is recognized federally, that's one. And then two, a tribe can choose to either take a grant from the federal money that funds IHS, or IHS can give money as a grant to a tribe to do with it what they want. So the Creek Nation in particular definitely has participation in IHS. There's not a separate grant that is funding the access points in this area, on this reservation land. But when you were in your third year, were you having IHS people like talk to you to try to recruit you?
Unfortunately, no. I actually had to chase down the IHS recruiters and the tribal recruiters and say, hey, I want to come work for you. I want to come work for you. Give me an interview.
Yeah.
So, I mean, the recruiting budget is, I think, very underfunded. Yeah. So nobody reached out to me at all. Like, I had to reach out to each individual tribe and IHS facility that I was interested in.
And I asked this just because some tribal nations are doing this, where like there's a ear, nose, and throat surgeon who had come to one of the newest healthcare centers through IHS at what was the Cancer Treatment Center in Tulsa, which became Council Oak. I was hearing about there is an ENT surgeon who was put through medical school by, and I don't know if it was this nation or a different nation, but medical school was funded. Was any of your education funded by the tribe?
Yes, I applied for and got the IHS scholarship while I was still in college. And so that completely covered my tuition. I still had to pay for like books, living expenses, but my loans were massively, I say were because I've got them paid off now, were so much lower than a lot of my colleagues that came out with $300,000, $500,000 in debt.
Yeah.
I was like $100,000.
Stay with us. We'll be right back. Are you on a direct primary care journey and looking for the right support? Whether you're a marketer, health benefits advisor, legal expert, coach, specialist, or even a supplement company, the DPC directory is your go-to hub for connecting with the DPC community. If you're a DPC doctor, you'll find resources to grow your practice. If you serve the DPC world, grab a free listing today and get discovered by doctors who need your services. Visit thedpcdirectory.com and become part of the movement shaping the future of healthcare. It's just wonderful. Congratulations on that you got the scholarship, but also it makes you want to bang my head against the window because you're an IHS scholarship recipient. There's not too many people, I'm assuming, who take that and go to become a physician. And then the fact that you didn't even have a recruiter, even with the limited resources, to me, that's bass backwards.
Yes, it is.
Oh my goodness. And so if there is a listener out there who is also an IHS scholarship recipient who's going to doctor school, like definitely listen into this interview because that's crazy. When it comes to you reaching out, saying, hey, I want to work for you, why didn't you continue down that pathway of becoming like to this day, still employed with IHS?
So for me, I started out working for my own tribe. I was happy as a clam. I was covering our critical access hospital with a handful of patients a day, covering the clinic. And then on my days off, which were Friday, Saturday, Sunday, I would usually pick up ER shifts at the same hospital.
Yeah.
And I very much enjoyed it. What got me was the tribe got into a financial crisis, I guess you would say. And one of the way the administrators decided that they needed to make more money was they started having patients come in at smaller and smaller time intervals. I actually took a picture of my schedule one time when I had a 5-minute appointment slot for a patient with multiple comorbidities. Oh, I couldn't have even filled her medicines in 5 minutes.
Yeah. I think that this is where, as I was hearing the transition from when Council Oak was created, the way that the administrator was speaking about, the innovation, the accessibility, the affordability, all of these things, I kept thinking that it is still an admin-run system.
It is.
Even though it is not the traditional BUCA plan system, it is still not direct primary care. And we've been talking very recently on the podcast, Dr. Stephanie Hune, who's in Missouri, in Rolla, Missouri, rural town just like yours, was talking about how when it comes to what is value-based care and what is not, this is where there's a distinction. What is system-based care and what is not system-based care, and how does that differ is a little bit easier. But for you, I mean, it doesn't matter where you are practicing, that the quality of care, the obnoxiousness of somebody telling you who's not a physician that you have 5 minutes on your schedule for this one person with, like you said, chronic comorbidities. What did your mind start doing then with the knowledge that this isn't tenable for you to be able to practice like you need to?
Right. I'd say like the straw that really broke my back was, like I mentioned, I was covering the hospitalized patients as well as the clinic patients. I had an hour blocked in the morning to see my hospitalized patients, and I was expected to follow up through the day with no-shows. If I had a no-show, that's when I go back and check on the hospital. So, well, what if I don't have a no-show? Or what if I have 20 patients in an hour? I mean, it's just not possible. So I was doing the best I could. I had a patient with a UTI, checked her white count, looking better, went and talked to her, feel better, great, awesome, go home, went and saw all my clinic patients. I was staying there late. I was there till probably about 9 o'clock, just checking charts, making sure I didn't miss anything, because you're going to miss something when you're having to rush through. I missed that her hemoglobin was 6.9. Jeez. Called her back, got her transfused, got her taken care of. Luckily, nothing happened. But I mean, she could have had an MSTEMI. She could have had a heart attack from that.
Totally.
And I was like, I can't keep being a part of this.
Yeah.
So that's when I started looking into other options and started applying at other places.
Yeah. And still within the nation or still within IHS?
Within IHS, yes. So when you have the IHS scholarship and you pay for 4 years of medical school with the scholarship, you're expected to work for 4 years for IHS or tribal facility.
Got it.
So I was only 2.5 years in, so I knew I had to work for another tribal facility or IHS facility. Yeah. So I applied with the Chickasaw Nation, with the Cherokee Nation. I was looking at IHS funded in Wowoka, which is primarily Seminole, but they're more IHS funded than tribal funded. So I looked at all those, and the best fit for me was back in Ada, where I went to college, is where the Chickasaw Nation has a hospital, and they had a hospitalist position open. And I applied, and I really liked their model. They were very patient-centered, patient-forward. So many hospitalist positions make you see 20 plus a day. Their average was 12 or less, so that you could actually spend time with people and explain things. So I really liked that. So that's when I went there in the very end of 2016.
Got it. And were you also having to do outpatient as well as inpatient?
No. Okay. That was a strictly hospitalist position with open ICU.
Got it. And I wonder, knowing that you had to at least commit 4 years to serving in IHS, when you were looking to transition away from Okemah, did you ask questions in particular of the different locations that you were looking at with administrators or doctors or staff? I really want to know what I'm getting into because of my experience in Okemah.
I found the best question for me to ask was, when did the last physician leave and why?
Yeah.
That's usually a good tell. And with Chickasaw Nation, the last person to leave that type of position left because they had advanced cancer and they had been there for decades.
Yeah. It speaks highly to the importance of that question. I think it's a very good question for any any person who's looking at an employed position. So what was that like? Because 2016, how long did you stay there? Because you eventually became the chief of inpatient medicine during the lovely pandemic era.
Yes. So I absolutely loved the week on, week off schedule. They were long, grueling days. 12-hour in-house shift is rough.
Yeah.
Plus the 2.5-hour round trip, driving down there and back, because I was dead set on staying in my own bed.
Sure.
And staying with my husband, who had previously been in the Navy and deployed, and we were sick of being apart. So I was like, no, we're living together. So the biggest thing for me was whenever I became more involved in administration at the very end of 2019, right before the pandemic hit, it was a lot of work. I mean, there was 1 week I worked 114 hours.
Jeez Louise.
Yeah, that was right at the end of March 2020, right when all this was really hitting.
Yeah.
And I felt like I was doing so good. I was like, wow, I feel like I'm making a difference in admin, because I came into admin when it was really important. Decisions were being made. Like, I was able to set up a tele-ICU, whereas before we were just family medicine. I say just family medicine and internal medicine, managing the ICU patients. Previously, if they were intubated more than a couple days, they'd be transferred. That was not an option during COVID anymore. Yeah. So we were figuring out how to do paralytic drips, prone, high settings on ventilators. So luckily, I was able to set up that backup with an actual critical care trained group to see what we were doing with our patients and advise us if we need to change this, that, or the other thing.
Wow. And that was via your telemedicine setup.
Yes.
Yeah, that's fantastic. Just in rural Nebraska, we had the third time I went back there as a resident, there was a camera for a trauma surgeon or trauma doctors to be able to, quote unquote, zoom into the room. To help in the rural access hospital that is Broadstone Memorial. So I totally get the importance of that. Going through the hell that was the pandemic for those people, especially who were in the hospital at that time, when did you then even think about, hey, one, clearly you just had to survive and get through your stuff. But two, at what point did you then say, I need an even different model of practicing. I've done Okema, I've done this ICU, I'm head here, I'm involved in admin, but it is still not what I wish to do in the future.
So a few different reasons. Number one, I will say I cannot imagine working in the hospital with a better administration or better colleagues. I mean, we had the absolute best doctors, respiratory therapists, nurses.
Awesome.
It was amazing. It was like the worst hell that I would never want to go through again, but if I ever did, it would be with them. So number one, I absolutely loved them. It was really hard to think about leaving, but my heart was never in hospital medicine. I wanted the relationships of primary care. So once COVID calmed down and when admin became more tedious than what I felt was like immediately helpful the way it was during COVID, I started getting antsy. I missed my primary care relationships I had with patient. Oh my God, it was so hard to leave Okema when I left primary care there. I mean, I had so many patients that really liked that I would spend the extra time and listen to them, even though that would put me behind and I'd get in trouble, but it was what needed to be done.
Yeah.
And then, I mean, I had another patient too, because being rural Oklahoma, not so many people are open-minded. I had a patient, she would fly all the way out here from Arizona. She was Native and couldn't find anyone to give her health care. She was trans, couldn't find anyone to give her hormone therapy, anything. And I was like, absolutely, I'll take care of you. I mean, people are people. Like, why do you have to be mean?
Yeah.
And this was in 2014, 15. This was before it became a little bit more common for people to be open to that.
Totally.
So I was the only doctor seeing trans patients there in my little town of Okema. I think I had 4.
Oh my gosh. I shake my head because, and then you look at today in 2025 where I read a meme yesterday, there's more people with measles than people who are playing trans sports. And it's really, what are we going to have a fit
We're
about?
Going back in time.
Yeah. So yeah, I completely am in the same boat. People are people. We went to human doctor school. Don't ask me to take care of a zebra, but ask me to take care of a human. Does not matter.
Yes.
Period. So I am amen to that.
People are people.
Yes. So I love this focus on people, being a people doctor, wanting to refocus and rezoom in on relationship-based medicine. Why direct primary care and not going back to another IHS clinic in a different, like a one with a similar administration or an outpatient clinic where maybe the doctors just don't leave because they like it, versus coming back here to Walika and opening your own DPC.
Yeah. A little wild, kind of crazy to go that direction. Some people might think I'm insane, but the biggest thing is I learned a lot about leadership and administration in my role at Chickasaw Nation. And I figured if I'm able to help navigate the hospital through a COVID pandemic, I could probably start a monthly membership primary care clinic. And worst case scenario, I always think worst case scenario. That's where my ER, ICU brain goes. Worst case scenario, I do go back to work for somebody.
Sure.
I mean, it's not the end of the world.
Yeah.
Like, at least I can say I tried.
Yeah.
So, and honestly, I was 50-50 on whether it would work or not.
Yeah.
And I just felt like I had to take the leap. So I set myself a goal of getting around maybe 80 members, 80 membership patients at 1 year. So February was 1 year. So we're now 14 months and I'm at 142 patients. So, I know, insane. I mean, because I'm really starting from scratch. Like, I didn't have a primary care panel that I took with me. I was being a hospitalist for 7 years, closer to 8, I guess.
Well, and you are in a place where there's supposed to be healthcare that is provided. And even your decades ago growing up, Dr. Burden-Greer is not old, but she is at least multiple decades. That could be
just
3
hit
decades.
40. We can put it out there. Just last month.
Love it. You're supposed to have the responsibility of the agreements, the treaties are supposed to be ending in people who have been discriminated against. There's so much history there that is a completely separate podcast. Robbed of its lands, people just, I mean, this is so, there's so much maddening history when it comes to the native people of what we call the United States of America and how rights and other things have been taken from native nations. When you think about, though, this idea the IHS is supposed to be providing health care and not just insurance to people in tribal nations, you still have people who are paying you to be their doctor, where again, you cannot go into IHS and have your personal doctor. Dr. Burden-Greer is a person's physical, real doctor. But why do people pay you? Why do people find value in Outlaw Medical? Because they're supposed to have healthcare covered, just like Medi-Cal recipients and Medicare recipients are supposed to have healthcare. Mm-hmm. And I'm making all these air quotations, like physically picture me frustrated and making these air quotes with my fingers as I'm asking her this. Stay with us. We'll be right back. If you've ever found inspiration, guidance, or the courage to launch your own direct primary care practice from this podcast, consider joining the My DPC Story Patreon community. Your support helps this grassroots effort going. Each week, you'll get extended interview content, monthly full-length check-ins with past guests, and bonus tips from AI workflows to behind-the-scenes insight into my own journey as a DPC doctor. Help me keep this movement visible, vibrant, and growing. Join today at patreon.com/mydpcstoryfan or check out the link in the show notes.
Yeah, that is one thing that actually I was a little bit worried about opening a DPC clinic in my area, because my area is about 21% native. That means 21% of people can go to one of the tribal facilities and get their health care. On top of that, we have Medicaid and other things where people will get quote unquote free health care. But when I opened, one of the things that I knew from my own experience is getting in to get established with a primary care. 4 to 6 months is pretty standard wait, and to see a doctor, maybe longer, because they have a big supply of nurse practitioners and PAs, but not so much on the doctor side of things. So people that wanted physician care, people that wanted access greater sooner than every 6 months, if you want to get in for a same-day appointment, almost always you're told to go to the ER.
Yeah.
Versus, I had a patient actually this morning, I haven't mentioned to you yet, I had a patient come to me. I saw her yesterday. She clearly has a a kidney infection. So she called this morning saying she was in a lot of pain, or her husband did. And I'm like, hey, give me 15 minutes to put on clothes. I'll meet you at the clinic and we'll do a Toradol shot. That's usually the best for kidney pain. And if you're not better after that, we'll figure out what to do next. So, I mean, I did that a couple hours before you got here.
Wow.
And that's just an impossibility within the system.
Totally.
100% you're going to the ER.
Yeah. And just as a side question there, what is the wait in the ER once you get there?
It's hit or miss. If you go at a time where they're not too busy, you might get in pretty quick. If you go at a time that a lot of kids get out of school on a weekday and everybody's coming in with their colds and flu and COVID, then it might be several hours.
Yeah.
So you're talking about the drive to the hospital because nobody lives next to the hospital. And then you're talking about the wait. And then you're talking about being seen, testing, getting out of there. Your whole day is the ER.
Yeah. Yeah.
Versus
calling you.
Less than 30 minutes with this patient.
It's amazing. And right now, your patients who've seen you, again, I'm so excited that you have so many. What is their geographic span? Do you still have patients flying from Arizona to see you? Because I think about how in my fee-for-service practice even, people would drive an hour and a half to see us. But what is it like for you in terms of the geographic footprint of your patients?
I'd say the vast majority are within a 45-minute drive. And for Oklahoma, that's not very far.
Yeah.
For reference, from where we're at right now, it's an hour and a half to Oklahoma City. It's an hour and a half to Tulsa. So a 45-minute drive from Seminole or Holdenville or some of these other towns that are nearby but still rural, they'll drive to see me or we'll do virtual visits.
Sure.
That's the majority. I do have some patients in Edmond, which is north of Oklahoma City, Norman, the Tulsa area that we do most of our visits virtual. They see me in person when they need to, but otherwise we handle most things virtually.
And do you physically go to different locations in Oklahoma once in a while to meet patients where they're at? Or do you, even if it's home visits, or do you just see them once in a while because they're coming here to Waulika?
I just see them in person in Waulika. I don't have any other locations that I travel to.
Got it. So I think about Waulika having around 800 people here, and then people are driving typically 45 minutes as the longest to see you. I just think that that's still not thousands and thousands of people. And yet you have over 120 people who are choosing to see you. I mean, this is where I think about Phil Eskew, JD, MBA, DO, who has said DPC can happen anywhere. And you are absolutely proving that. That's why I'm so honored to be out here. I'm so excited to have your words be shared amongst the airwaves, on the airwaves, because for those people who are hesitating for whatever reason, it's like you are definitely providing a so unique and hopefully not unique example in the future, right? As more people do this. But I wonder about the things that you're seeing, not only in people who are not of the Creek Nation, but who are also just in rural America, in rural Oklahoma. What are the medical issues, especially like when it comes to chronic disease, that you are seeing, and how are they different if a person is of a tribal nation?
So Native populations tend to have higher rates of diabetes, and most people know that, but most people don't know Native populations have a much higher rate of autoimmune disease.
Wow.
Which I find very interesting, and that's one of the things that kind of got me interested in medicine, as my mom has a lot of autoimmune issues, rheumatoid, lupus, things like that. So I had kind of a special interest in those things, and I mean, I would say last week I diagnosed a new patient with lupus because she had been through the system, given 15-minute appointments in and out, never had the hour-long appointment that she and I had, talking about everything in detail. And I'm like, you're checking all the boxes of lupus. And she even described a butterfly rash. I'm like, okay, well, I think this is what's going on. Let's get you checked out before we go down these other routes. Yeah. And that's what it was.
Wow. And when it comes to, I go back to this transition period that the Creek Nation in particular had to opening this brand new facility, where one of the things that they touted was, we're going to have amazing mental health care, behavioral health care access. We're going to do work in the community to not make mental health, addiction, alcohol, substance use disorder a stigma. Do you think that has changed within the nation in particular when they are supposedly having access to more healthcare options?
I'm not working within the tribe anymore, but I have seen that they are doing more to try to make access happen. So I do think they're making great strides. I mean, it's been almost a decade since I worked for the tribe. And from what I've seen, it's a much better administration. It's much better as far as what their goals are, putting patients first. And so I think lots of strides are being made, but it's never enough.
Yeah, totally. But that is good that there's a positive change there. That's really great. when it comes to your typical day, because you live you live a mile and a half from your clinic. That's just like me. Oh, I got to see you. I'll be there in 15 minutes, but it's actually 2, but I'm just going to say 15. For you, what does that look like in terms of your typical week? Do you go in every day? How many patients do you see on your busiest days?
So it kind of depends on the day. I'm there every day of the week except for one day a week. I work for Woka IHS.
Okay.
That's kind of my side gig to help fund things.
Yep.
And my hours are 9 to 6 because I wanted people, when they get off work, to be able to have access to a doctor.
Sure.
So a lot of the teachers in town get off at 3 o'clock. A lot of people that, work the 9 to 5s, I can see them at 5:30. And then I do the first Saturday of every month, I'm there for a half day.
Okay.
So I have a handful of patients that can only see me on Saturdays, and otherwise they just wouldn't have a doctor at all.
Yeah.
So I like being able to have that kind of flexibility.
Yeah.
And then it's a Saturday morning now, and I was able to take care of my patient this morning. I don't guarantee weekend availability or after hours availability, but if I'm sitting around in my nightgown watching Grey's Anatomy on Netflix, then I can roll on some clothes and meet you and take care of you.
I love that. And how much of your everyday work is telemedicine versus in person?
The vast majority is in person.
Yeah.
Yeah, I would say maybe 10% is telemedicine.
Okay.
And my patients know that I like to stab them. They know that I like to, if they have something, I had a patient with a cyst on her face that everybody else had refused to remove because they were worried about scarring. She's like,
wow.
I don't care about scarring. I was like, okay, well, if you don't care about scarring, I'll do my absolute best. And I, did some buried sutures after we removed the inclusion cyst, and she's been very happy with it. Knee injections, PRP injections, platelet-rich plasma, mole removals.
Yeah.
People know that I like to cut things.
Good, solid family medicine.
I like to joke at them. Like, patients know I like to stab them.
Oh my goodness. Well, I think it's great also that you're able to, because there have been some residents who, like I met one in the Central Valley in California who asked, do DPC doctors have opportunities to learn procedures? Because I'm not learning anything. And she's going to a very, very well-known medical school. And so it was very sad to hear that, because also being a person who loves rural medicine, who loves being able to do these things, everybody should be empowered to be able to choose to do these things after residency and be trained to do them. So I think that's great.
Shout out to my attendings and training too, like Dr. Sally Ann Patton. I can remember presenting a patient to her that had a large lipoma on his back, and I was like saying that we needed to refer to surgery. And she said, absolutely not. We're not referring to surgery. We'll schedule him for a procedure and we'll take it out right here in the office. I was like, oh, we can, even if they're that big? And she said, yeah, absolutely. I remember that so vividly. And then a colleague that she was in residency with me, her Dr. Hernandez and Dr. Sayer worked to open a free procedure clinic for like homeless and underinsured. So we did procedures a lot heavier than other programs, I think.
Yeah, that's great. It's great, especially because those skills are serving you now.
I will say the very last patient I had at Creek Nation, she needed a biopsy. It's so hard to get a biopsy because it was just me and one other doctor that pretty much did procedures at the time for the whole tribe. So you would have to refer to dermatology. If you don't have a cancer diagnosis, you're not getting a referral to dermatology. So I biopsied her, turned out to be melanoma. She did have it in her lymph nodes. I met her about a year and a half later, and she hugged me and said I saved her life because I was able to actually get her the diagnosis and get her the treatment. And I was so glad to be able to lean on my training and know that I'm able to do that kind of thing for people.
That's awesome. How did you look at pricing for your services and your membership? Because there are other DPCs in Oklahoma, but again, there's only one Dr. Burden-Greer. So how did you determine your pricing?
So I pretty much looked at every place in Oklahoma and saw what they were pricing and tried to pick kind of a price right in the middle. But then I also went a bit lower on my young adults, age like 20 to 35. I set their price lower at just $50 a month because we have a big population here that do pipelining, welding, like working young guys like my family members that don't ever see the doctor because they can't take off work. So that's kind of why I set the Saturday hours and the after work hours. And I set the price lower because job variability is all over the place, especially when you're involved in pipelining. It's hit or miss. You save your money when it's good times and you pinch the pennies when it's bad times.
Yeah. And when you look at your overall, because you go from, and correct me if I'm wrong, $25 per member per month for a certain age group, as long as they're with a person who's in that adult range.
Yep, that's children.
And then you also have from 32 to 64, a $75 per member per month membership.
So the youngest are up to 19 kids with a family member, 25. And then 20 to 35, the young adult range, are 50. And then 36 plus are 85.
And then on your website, it says age 64. So are you still opted into Medicare because of your other quote unquote side gig? I would classify as a side gig job.
Yes. I'm still opted in because I still need that 1 day a week to kind of make me feel secure. I'm thinking when I get to around 200 patients, I'll feel secure opting out. Yep. But for right now, I like having that safety net of that set income, working that shift there once a week.
Yeah. And when it comes to ideal panel for you to maintain your lifestyle, but also to make sure that you're not making your list go down to, and it would never happen, but the 5 minutes per patient situation that you had before in Okemah, what are you thinking is your full number?
So I have two different ideas in mind. If I stay right now as a micro practice, just me answering the phones, doing everything, doing my own phlebotomy and my own ultrasounds, everything, I'm thinking 300 would be the sweet spot. If I decide to hire an MA or an LPN, I'm thinking I could pretty easily do 500.
Yeah.
But I'm honestly really enjoying not being in charge of anyone besides me and my patients after the administrative role I had before. This is just such a nice break.
Well, especially during the COVID pandemic, too. That's a lot of coordination.
It was.
Because you also are not only board certified in family medicine, you're also board certified in obesity medicine. And you have offerings on your website just for people who are wanting to see you for obesity medicine services. How does that work in terms of if a person is already a member? And then who are the people who are coming in just for obesity medicine services?
Right. So if somebody is already a member and they want help losing weight, I don't charge any extra. I just consider that part of primary care. And I just spend extra time with them at no extra charge. But if somebody comes to me from outside, they say, I love my PCP, I like them for everything that they do for my blood pressure, I just need help losing weight, and they weren't sure what to do, then I kind of see them as a consultant, and I will send my consultation note back to their primary.
Got it.
And I will strictly focus on lifestyle, check any labs that may not have been checked. A lot of people forget about B12, iron, things like that affect metabolism that may not be checked in a routine panel from primary care. And we decide what medications are best, what type of diet and exercise they need to slowly start incorporating. Because if you try to do too much at once, it's just not going to work.
Totally.
We focus mostly on habit stacking and goal setting.
Yeah, that's great. And in terms of the balance of potentially 300 people if you were micro practice going forward versus if you had somebody and you had a higher number of patients, how do you foresee obesity consultations playing into that number?
I like kind of where I'm at. I think I'm about a third obesity medicine and the rest is primary care. And I think that's a good ratio.
Yeah.
I think if I keep that ratio, it'd be just fine. If I ended up with too many, over half obesity medicine, I think it would be overwhelming because I do see those patients at least once a month.
Sure.
And I spend a lot of time counseling. They're a little more involved. Honestly, I probably underpriced myself with my obesity membership, but it's already set, so I'm going to keep doing what I'm doing.
Yeah, and you can always change.
Yeah.
When it comes to the coordination of you doing a consultation note and you sending it to their primary, one, I think about how many times does a person who I send a note to, one, receive it, and then two, do you get any people on the outside of your DPC wanting to talk more with you, collaborate for their patient who they're taking care of as the primary?
I haven't had a lot of primaries reach out to me directly. I actually randomly had a church counselor, a preacher, reach out to me saying that he was working on lifestyle and behavior and mood, obesity, and just primary care. And he reached out to see about if he could maybe help pay for some of his members' primary care or obesity care.
Yeah.
So that's kind of in the infancy stages.
Yeah.
But for the most part, when I first started, I went around to different primary care doctors and said, hey, I'm obesity medicine. I have way more time than you guys. have to do a lot of counseling.
For sure.
So if you want to send someone my way, send them my way. And that's where most of my referrals have come from.
That's fantastic. And these people are also seeing you once a month in person, or are they doing everything virtually?
I'm mostly in person, but I have some that live a little further away. McAllister is a little over an hour away.
Okay.
So I maybe see them once in person and then the rest virtual. Same thing with Norman or further places.
Okay. Awesome. And
I hate naming these towns like everybody knows where they're at.
it's okay. People can access the map. I've said Superior, Nebraska so many times on the podcast, so people can look it up. Have you already had medical students or residents ask, hey, can I actually come out and see what you're doing? Can I shadow? Can I learn from you being a DPC doctor in rural Willika?
Yeah, actually, when I was in the kind of transition period, I was still working part-time down at Chickasaw Nation as a hospitalist. There was a student rotating there from, I think she was from OSU, Oklahoma State. And she was very interested in lifestyle medicine and obesity medicine. And so one of the docs told her about me, and I was like, yeah, absolutely, come on out. And she rotated with me for a day. I just had her get the histories and present the patient like you normally would. And we talked about the plan. We talked about lifestyle. We talked about all the different mechanisms of the medicines. And then I was like, you need to learn how to draw blood. And so I let her draw my blood, and she was stoked about that.
Oh my gosh.
It was before I had my point-of-care ultrasound, so I didn't get to let her play with that. But she was stoked to draw some blood because she saw me. I think I drew blood on somebody that morning because we were checking iron, thyroid, vitamin D, vitamin.
And do you have point-of-care lab equipment in your clinic?
So everything is send out.
Okay.
Quest or DLO is what it's called. They will send a courier to pick it up, and then I get the results the next day.
Okay, I'm like so jealous when you said courier. I'm like, oh, girl has a courier and I can't get a courier.
Oh, I'm fancy.
Oh my gosh, I love that. I
think it helped because in town there is a PA that she's been here for a long time. I think she's getting close to retiring. She's hired a nurse practitioner that's picking up some of her panel. So they were already coming and picking up labs for them anyway.
Yeah.
So whenever I started, even though I'm lower volume, it's, we're already going to Willika anyway, we can pick up.
Yeah. I will throw a shameless plug for anyone. If you have any Quest contacts, especially in California, please tell them to reach out to me because I have asked Quest multiple times. I'm the only person who has a Quest account in our county, and they won't come. So it's maddening, but I'm very happy for you. I'm not happy for Calaveras County. So when it comes to you thinking about your medical journey, and when it comes to students coming into your clinic, clearly you said you should learn phlebotomy, which that's a very big, very big, very, very big pro tip. I am so frustrated that I did not learn that skill in medical school. What other tips do you have for people who are coming up in training or they're in residency and wanting to do independent DPC practice, especially whether it be rural or suburban or urban? What are things that you really encourage people to think about, whether it be business learning, whether it be procedural skill learning? What are things that you recommend people learn to be confident in before doing something like DPC?
So I think the biggest thing is to focus on the variety of locations and the variety of attendings that are teaching you. That way you have exposure to different styles, you have exposure to different ways of learning and taking care of patients. So that is one thing that I liked. Even being at Mayo Clinic, we still rotated at the Naval Hospital to do our newborn rotations. Wow. And I rotated at the University of Florida Shands to do trauma rotations. So I feel like I got a lot of variety, and I think that variety is what really helped. And even starting in medical school, we had some of our electives. I picked rural medicine to see this doc out in rural northeast Oklahoma, and he covered a hospital and had his panel and covered a nursing home, and I thought that was pretty cool.
Yeah, spoken like a true family physician, his full scope. I love it.
A lot of variety.
Yeah, I love it. And when you think about not only just where you could go if you remained a micropractice doctor or if you had staff, like you mentioned, what else do you see happening for Outlaw Medical now that you've been doing it for a while now? You have over 100 patients. I think about how Dr. Burden-Greer, who opened, who was not sure if it would work, so to speak, has already proven that it's working, period. So what do you foresee yourself doing in the next 3 to 5 years?
I mean, just enjoying the ride mainly. Like once at this rate, I'm going to be to my happy place within a year or two. And I'm just loving the life, man. I really enjoy Dr. Cook down in Ada. She's the closest DPC doctor to me. So I think she and I have talked a little bit about maybe covering for each other to allow us to have more true vacation.
Yeah.
Versus right now when I go on vacation, I'm still answering texts and phone calls and things like that. Yeah. But I see a little bit more of a setup, an agreement between me and her to cover for one another to have real vacations.
Yeah.
But other than that, I love my clinic. I love my patients. I mean, I'll show you the clinic later. I don't anticipate a lot of need to expand.
Yeah. No, it's fantastic.
I'm not trying to open multiple sites. I just want to take care of my patients and live my life and actually have time for my family for once in my life and animals and all the things.
And be financially able to do these things without having to see 2,000 to 4,000 people. It's fantastic. And then, so speaking directly to those people who are not necessarily committed to doing DPC yet, especially, what would you say to that person, no matter what healthcare system they may be in or whether they're in training or not, or already in attending, what would you say to that person to challenge themselves to think about when it comes to the reality of DPC versus being an employed physician?
Go shadow a clinic. I mean, like I mentioned, Dr. Cook let me shadow her clinic. The whole reason I even found out about DPC was I went to a DPC mastermind that Dr. Kelsey Smith was hosting, and it just made me think, oh, maybe I can actually do this. And maybe you don't want to start your own DPC, but you could work for a physician-owned DPC group and still have the lifestyle without the overhead and the admin.
Yeah.
I mean, there's so many ways to do it.
That's awesome. And I do think that's really great advice, especially because the movement is growing so quickly. Do you ever think that if someone said, hey, I'm in Edmond, I'm in a different place in Oklahoma, could I open a branch of Outlaw out here? What would you say to somebody like that?
You mean open a branch like
of your own DPC
clinic? I honestly hadn't even thought about that. It has not crossed my mind. I mean, I'd be willing to help and get started, I'm sure.
Yeah. I think about that because it is very true that there are a lot of people who are looking at this in that DPC is less intimidating if they don't have to do the day-to-day inventory, cleaning the toilets, doing the books, all the things that we do. But I think about that because with branding, with you establishing the quality and the type of care that you bring to Outlaw Medical with obesity medicine, but just also with these procedures that you're doing. I think about how would you even look for a person to replicate, but still be a very independent physician under your brand?
Yeah, I think it'd be hard to find the right person. But I mean, there's plenty that I know that I think would be amazing that I've had as colleagues before. And if they ever wanted to run away and escape the system, I'd be happy to help them escape.
Yeah, that's awesome. We're going to continue the conversation over in Dr. Burden-Greer's clinic. And I'm also going to be asking her about her experience with this COVID crisis that she was managing as the chief of inpatient medicine at the Chickasaw Nation, and how that translates to how she thinks about being prepared during natural disasters, especially. Just recently in Oklahoma, there was very significant tornadoes, especially, and how to be resilient as a rural doctor, but also just asking questions about the ins and outs with the physicality of what she has as tools in the space that she has. So join us over in our Patreon community, and we'll continue the conversation over there. Thank you so much for having me out here. This has been extra special, and I'm so glad that we were able to do this.
Oh, I'm so glad you came out. Like I said, I've been fangirling your DPC podcast for years, way before I actually got the nerve to open my own. So
it's awesome.
You help lots of people.
Thank you for listening to another episode of My DPC Story. If you enjoyed it, please leave a 5-star review on your favorite podcast platform. It helps others find the show. Have a question about direct primary care? Leave me a voicemail. You might hear it answered in a future episode. Follow us on socials at the handle @MyDPCStory and join DPC Didactics, our monthly deep dive into your questions and challenges. Links are at mydpcstory.com. For exclusive content you won't hear anywhere else, join our Patreon. Find the link in the show notes or search for My DPC Story on patreon.com. For DPC News on the Daily, check out dpcnews.com. Until next week, this is Marielle Conception.